Hello and welcome everyone to Balance Eating Disorder Treatment Center's webinar with Dr. Mohammad Herzallah and Jillian. We are so glad you are here today. Hi, Alyssa, Christine, Fatima. As everyone's coming in, please feel free to put into the chat perhaps how you heard about the webinar, what you hope to get out of the webinar today. We love to know where you're from too. That's also super helpful. The way we'll conduct today's webinar is that we will start with a presentation from Mohammad, about 30 minutes. And then from there, Jillian is going to start to ask some questions, and we will also have you ask questions and engage as well. If you're joining today for Eating Behaviors, Part 1, what if we let go of diagnosis, with Dr. Mohammad Herzallah, myself, and Jillian from Balance Eating Disorder Treatment Center, you are in the right place. Thank you so much for being here. We'll get started in just 1 minute, 5 minutes after 12. Again, please do feel free as we move through our conversation today to put your questions in the Q&A. They will stay in the question answer box until we answer them. And we will get to them in about 30 minutes when we open up this for a panel discussion. Again, today's topic for our Balance Professional webinar is eating behavior. What if we let go of diagnosis? And this is part 1. We'll talk about part 2 coming up in about a month. I'm so excited to introduce my 2 panelists in just a moment. I'm Julie Mellk. I'm the outreach manager for Balance Eating Disorder Treatment Center. And we are a treatment center that's located in the heart of Manhattan in the Flatiron District. We're a premier outpatient treatment center offering boutique and individualized programs using evidence-based practices. We treat the whole spectrum of eating disorders, and our philosophy is a very integrative treatment model. We use CBT, DBT, these are just a few examples, to creative art therapies, yoga, group and family therapy, as well as individual meal support, and we also have individual one-on-one nutrition counseling. We also are human-first, holistic, LGBTQ allies. We are healthy at every size practitioners, intuitive eating-based, and we offer both virtual and in-person outpatient services. So welcome. Our mission at Balance has always been to empower individuals suffering from eating disorders with the tools and skills necessary to heal their bodies and their minds. And we do believe that full recovery is possible. The staff at Balance have a lived experience of that, and I think it comes through in all of our services. I'd love to introduce today Mohammad, Dr. Herzallah. He is a neuroscientist and a physician entrepreneur, a research scientist at Rutgers University, and the founding director of the Palestinian Neuroscience Initiative at Al-Quds University in Palestine. He obtained an MD from Al-Quds PhD in behavioral and neurosciences, exploring biomarkers for the diagnosis of mental ill health to digitize and democratize mental health. Mohammad also received the Young Arab Neuroscientist Award, the TED Fellowship, the Aspen Global Leadership Network Fellowship, and was made one of the 500 most powerful Arabs in the world. Mohammad has been selected for the Lancet Commission for Global Mental Health and featured by Forbes, Science, Nature, and as I mentioned, TED. Welcome, Mohammad. Don't forget to unmute yourself.
Thank you very much, Julie and Jillian. Absolutely a pleasure to be here.
So excited to have you. Also, we have Jillian who's joining us. Hello, Jillian. She is a research coordinator with us at Balance, and she tracks treatment efficacy, or the success rate. Jillian's also a PhD candidate in behavioral and systems neuroscience at Rutgers University. Her research lies in the relationship between neurons, behavior, and clinical symptoms. Jillian also has an experience as a substance use counselor and intake coordinator at Balance, and is currently a teaching assistant and published author. Welcome, Jillian.
Hi, thanks.
Hi. A few objectives before I hand it over. Today, we will distinguish mental health and ill health. We'll also rethink what we call well-being or mental health and diagnostic constructs. Finally, we'll investigate the different layers that govern eating behavior. So now I hand over the presentation to Mohammad.
Thank you very much, Julie and Jillian, for having me today. It's a great pleasure to really introduce some of these concepts that are revolving around some of these ideas related to mental health for all and mental health as a continuum, as opposed to the dichotomies that have been occupying mental health for the past century or so. And the reason behind this is basically there are a lot of issues with the current diagnostic systems that we use for mental health that we call psychiatry or mental disorders, which is a term that through this kind of presentation, I would hope that actually by the end of this presentation, we would come to the resolution that it might be replaced with a much better way of thinking about it. So in general, whenever you think about mental health, let's think about mental health in the context of numbers. So for the WHO, 1 in 3 humans suffers from mental ill health. And that's actually, I think, is the more befitting term, ill health as opposed to health. So always kind of cemented in the health concept as opposed to the disorder concept. But if we're talking about 1 in 3 humans, this is a huge problem that is facing humanity at this point. And I think very little, unfortunately, is being done at, multiple layers, unfortunately, to tackle this problem and to find proper solutions that would promote mental health in the general concept of it. If we focus this a little bit more on what is termed as eating disorders as a general category, we're talking about 9% prevalence in the US and an echoing prevalence worldwide. And in a lot of cases, this is the tip of the iceberg. This is what we know. This is what we have, managed to screen in individuals, and let alone what is not known to us and what is actually kind of the hidden part of this monster. And this is all pre-COVID-19 numbers. And needless to tell you what happened actually to the world in the context of COVID, and how basically everything changed in the way that we look at these constructs or these problems that face our conceptualization or understanding of what is mental health. So that being said, I'm sorry, I think I'm moving backward, not forward here. So what is mental health? So as a definition, it's thought of, and I'll read through, it's thought of as a capacity of thought, emotion, and behavior, which would ultimately enable the individual to have a proper positioning within their context, within their environment, and be able to contribute to community. And if you think about what is mental health in the context of the absence of mental health here, usually I like to use the 4 Ds of mental ill health, which relate to danger, deviance, distress, and dysfunction. So it's basically the opposite of what is the description of mental health in the context of functionality and in the context of self-harm, in the context of not being able to, in the context of being of a particular danger to self or to others, as opposed to having a clear set of symptoms that are expressed. And again, this gets us to another discussion, which is what is normal? And do we emerge out of this kind of mental health discussion thinking about normal and abnormal? So I want each and every one of you to think, how would you define normal in this kind of regard? Which is a topic for another discussion, hopefully. So, but knowing what is mental health, we can define the absence of mental health in the context of biology, behavior, environment, and development. And again, I really am a big fan of this, what people call the biopsychosocial model of mental health, although I come from the background of being like an avid biologist, an avid neurobiologist, I work with neurons, I record from neurons. I like to think about how the brain functions and think about, basically the neural basis of things. But I can tell you right off the bat here, it's not the only thing at play here. It's not just the brain, It's the brain in a context of a lot of things, and even sometimes the brain is the secondary vehicle in this kind of regard. So as such, the absence of mental health, or like what I like to call mental ill health, but I'll use the word disorder here just to follow the regular conventions in this kind of domain, is basically the disturbance of what I just mentioned. The disturbance of thought, emotion, and behavior that ultimately, in the context of biology, in the context of behavior, in the context of environment, as well as following this through development. But is this it? Is there anything else that we should think about whenever we consider mental health or mental disorder? Apparently there is. And as you could think, actually, there's the concept of happiness. And again, I'm not just thinking about it as a biologist or as somebody who wants to pathologize human behavior in this kind of regard. So what is the level of satisfaction? Could somebody have a mental disorder and be happy at the same time? So again, a question to ask. And is that it? Is there any other layer that would actually kind of be considered in this kind of understanding of what is mental health? And I would like to direct you to the concept of well-being. And well-being is basically the evaluation of satisfaction, the evaluation of happiness. And how can we link all of these together? Historically, mental health was thought of as, the kind of distinction between normal, and again, I would like to revisit this at the very end, and disorder. And you would consider a lot of multidimensional expressions of features, clinical features that we call symptoms. So here I put a few here, and signs and symptoms, and of course, the clinicians would know the difference in this kind of regard, where we basically we rely a lot on symptoms in the field of psychiatry and mental health. But basically, insomnia, binging, mood fluctuations, paranoia, anxiety, compulsion, obsession, avoidance, et cetera, all of these are signs and symptoms, and most of the symptoms that you can actually ask a subject or an individual about. And ultimately, based on scores that are composite, you would actually then give a 1 or a 0. Has a problem or does not have a problem. Again, disorder, normal. And historically, where does this come to mental health from? It comes from infectious disease, where somebody has a disease if they have the causative infectious agent. The normal does not have the causative infectious agent. And I'll leave it to you to think, does this actually work in this particular context or not? If you have this kind of multidimensional expression of these different features, these different behaviors, what is normal? So instead of this kind of binary classification, which, by the way, most of the diagnostic systems that we use these days, the DSM, the ICD, are built on, can we think a little bit differently about it? Can we extend these boundaries of normal and disorder to be as inclusive as possible? In other words, can we demolish the binary to create more of a continuum, a spectrum that not only treats having or not having a problem, but treats the different, murmurations, the different ways of this expressing in an individual. So we start with the individual as opposed to starting with the group that represents the individual. And can we actually, the question to ask here is, can we do this in the context of defining what is happiness for that individual and what is well-being? So that being said, this is just, again, this is the outer layer of what I'm going to talk about today. And it's more of the crust of the system, where we can actually interrogate these particular phenomena by literally asking the individual, or collecting that particular type of data by asking about the symptoms. And there's very, very well-established system in terms of psychometrics and structured clinical interviews, and all of these diagnostic systems. They're not obsolete. Don't misunderstand my proposal here. Quite the contrary, they're very, very important. But probably we need to think about repositioning or repurposing what we do with these particular tools and sets of tools in order to make them as valuable as possible to the individual at the individual level. So let's think about this as a layered system. And again, I come from this background of studying chaos and randomness in neural systems and behavior, and basically trying to appreciate how we build more of like hierarchical systems with multiple layers, and how do different units interact to produce a system that then actually interacts with other systems to produce a corpus of other things, you know. So if we want to think about this particular complex system, if I may call it, with the top layer being these features or clinical features or symptoms, and thinking about them multidimensionally as opposed to binary, 0 or 1, normal or disorder. So what are the different components of this? And the different components of this, to me, based on my own studies and the data and background and so on, would actually be different from those that actually would come from different background, of course, you know. But at least I tell you, I'm not here to propose a new theory. The field does not need a new theory. It needs more of empirical ways of trying to solve this problem with the tools that we currently have. This is by no means a theoretical perspective. It's more of how can we properly organize the huge amounts of data that we have collected over the past decades in order to think more about these problems in a way that maybe we don't need what we call diagnoses here. Instead, what we need is actually the proper stratification of these different behaviors, these different symptoms along these layers. So in this kind of context, in this way of thinking, I'm proposing that maybe one of the layers is what I call here behavior, which is basically, in other terms, people call it cognition, in this kind of regard, and it defines some very basic, simple functions that could be gauged, could be measured. Let me give you one example. This is actually a field that we call reinforcement learning or feedback-based learning, and some people call it category learning. And this is actually a very well-established set of paradigms in cognitive science, in behavioral science, in even machine learning and computer science. Even we use this for robots, to train robots, how to kind of observe and learn from the environment around them. So what is it about? What is it that we actually kind of train these robots on in terms of learning from positive and negative outcomes? So if I give you the option to choose between a pepper and an apple, and then let's assume that you choose the pepper and you don't like chili, then this is more of a negative outcome. I mean, like more or less here. But if you select the apple, then actually this is more of a more rewarding stimulus, given the sweetness of the fruit here. So the first was a negative feedback, and the second was a positive feedback. And with more repetitions, more trials, the behavior is going to be more leaning toward selecting the apple on subsequent encounters, if you were given the choice between an apple and a pepper. But it's, again, not just that. It could be positive feedback and basically no feedback. So if we compare an apple with a maple leaf, if you select the maple leaf, you would not have any kind of taste preference. It might be even toward the negative. But if you select the apple, maybe you like apples, and then actually it's a positive outcome. And then in future encounters, you would actually avoid the maple leaf and actually focus more on the apple. And the last but not least here is the negative and the neutral. So pepper or maple leaf, and then actually you would kind of, if you would select the pepper here, again, it's going to be a negative outcome, and the maple leaf is going to be basically no feedback here, because it's just it does not convey positive or negative. And here in this kind of context, you would avoid the negative. If you were given the choice between this or that, you would avoid the negative represented by the pepper and go toward the neutral, which is the maple leaf here, but certainly not to eat it. So basically that's actually if it's more of a selection that we're talking about here. So this could be crystallized into the whole concept of a stimulus response outcome. And again, this is courtesy of B.F. Skinner and a lot of great scientists in the past who actually worked extensively on defining what is behaviorism as a field of study, as a field of inquiry. And then basically it looks at what we encounter in the environment in terms of stimuli that gets processed. Then there is a response, whether actually you approach or avoid something, and there is the outcome, whether it's in the positive direction, in the neutral direction, or in the negative direction. But let me just put a little bit of a spin on this. Again, trying to put this as a layer beneath the first symptoms layer that we described earlier. And again, for the stimulus, you could just, by looking at a particular stimulus, such as the shape of the pepper or the shape of the maple leaf, you could define whether this is a rewarding or a punishing stimulus. And then based on that, you could make actually the response, which would be in the approach, you want to reach out, or avoid, maybe not do any action, in the active or the passive sense in this kind of regard. And the third axis for this is basically whether this is a positive or a negative outcome. Do I get burned by the pepper, or do I get the sweet taste by the apple? And again, think about this as the very basic level of behavior. By the way, fruit flies can do something to this extent. Mice and rats, monkeys. So basically, it could be supported by the basic neural circuits that any of these basically species possesses. It's not a human thing. And again, this produces a huge advantage for us, which is in some way we kind of get rid of language as a barrier to gauge behavior, and potentially even culture, which is a big thing for humans, except for basically the cover stories that we put there in terms of maybe some cultures, love peppers and hate apples, which is kind of a different way of thinking about this dilemma there. But the other thing I would like to add on top of this is I want you to think about the shape, the dimensionality of the stimulus response outcome chain here. So remember, this is a cube. It's a space. It's not just how does somebody do on a stimulus response outcome as a serial linear thing. No, it's not. It's a point in a three-dimensional space. And this way, you can actually properly distribute responses and distribute individuals based on their performances according to the requirements of the behavior that is being studied in this kind of domain. So let's take this and actually place it as a layer of the system that we're trying to study there. So as you can see here, we stratified symptoms. We got rid of what is called the disorder or normal, and just displayed all of the multidimensionality of the symptoms. And beneath that, we tried to, for the same individuals, gauge their behavioral correlates by, for example, one of the examples is reinforcement learning, and studying where are they placed in this three-dimensional space of stimulus, response, and outcome. And ultimately, what remains here is our next topic, which is what is the neural circuitry of feeding in this kind of domain, which is basically how can we understand better what happens in the brain in this kind of regard to try to stratify that even further. And I would like to share this with you. This is actually from a review paper, and it just shows very briefly here and very abstractly the hypothalamus with related structures that actually are involved in what we call feeding behavior. And as you can see, there are connections between the arcuate nucleus, as you can see here, the ventromedial hypothalamus, lateral hypothalamus, paraventricular nucleus, and many other areas. And I would like to focus on previous concepts that we just discussed. Ventral tegmental area, which is the area that has dopamine. And we know that dopamine is very much involved in the motivation for behavior. The nucleus accumbens, which is related to basically a motivated behavior again, and the valence of is it positive feedback, is it negative feedback? The parabrachial nucleus actually, and it's related to peripheral input coming from the gut, coming from the rest of the peripheral systems, and many other systems. This is again just a very concise simplification of the system. And again, this is basically what happens before food intake. So I want you to feast your eyes what happens after we eat. And just like basically for the purposes of admiring this a little bit further, let's just put it on its own here and just think about it together. Do you think in any way that we could actually really just say, oh, I want to study what happens when fat is being consumed and it's really kind of playing with these neurons in the arcuate nucleus and therefore affecting its connections to the paraventricular nucleus? Do you think this is possible in this kind of picture? And I really can tell you here, it's, good luck, because basically this is what we call in like mathematical sciences, a complex systems, a dynamical system, which is a system that has multiple moving parts that are changing all the time. And it's almost impossible to say A leads to B, and then B leads to C, and then C leads to D. It's a circuit, it's a network, as opposed to kind of these serial processing approaches. And therefore, it's, I wouldn't want to say impossible, because then I would be out of the job as a neuroscientist, but basically it's very difficult to gauge the functionality of these circuits without really appreciating all of these very different moving parts, and without even changing the way that we think about the brain, not as a computer. The brain is not a computer. The brain is a complex system that knows how to deal with randomness and chaos by using these particular approaches, in terms of these kind of multiple, very variable, very dynamical systems that actually keep changing all the time. So basically, if we place this as the last layer of what we're talking about in this kind of context, and think about the versatility of what we're trying to build as a layered system, starting with a neural circuit, whichever way we can gauge that neural circuit at the whole brain level. I'm just putting the hypothalamus here because it's relevant. And then basically trying to measure the function that is related to these particular neural circuits. Some example would be reinforcement learning and learning, category learning, or feedback-based learning, whatever you want to call it. And then put the full stratification of the symptoms here. And therefore, we would have this kind of complex multi-layered system that would allow us to, instead of saying eating disorder, no eating disorder, it would be the stratification of all of what we're talking about here, from the circuit to the symptom. One of you could come up and say, so what? It's just making things much more difficult. I already have patients and I can actually kind of treat them now with the current systems. Yes, but what's the response rate? And what are the consequences of giving somebody the tag as having a disorder? And the other aspects of this are we actually changing the underlying chains of causes, if I may call them here? Are we modifying the reasons, the actual reasons why this started altogether? And last but not least, what does this mean for treatment? And what does this mean at the community level? Can I just basically secure the amount of professionals that is needed in order to tackle such problems in the community these days? 9% of the population we're talking here. So do we have enough healthcare professionals to tackle the prevalence of eating disorders in the US? Only in the US. I'll leave this to you to think about. So what if we think about it differently? What if instead of saying Mohammad and Jillian are in this category, and therefore I'll treat them with 1, 2, 3, 4 that are for this category, as opposed to saying, oh, Mohammad has more of an avoidance aspect of things that are echoed by particularly more avoidance learning from negative feedback with positive stimuli and actually a higher activity in the limbic system, as opposed to Jillian, who has avoidance, but more of basically avoidance of positive feedback with negative stimuli and more inability to process things in the orbital frontal cortex. Same symptom, very different pathways. And maybe they're both affecting mine and Jillian's, functionality or, distress levels or danger. But at the same time, the approach it should be very different in terms of how to tackle my case as an individual and Jillian's case as an individual. We're created, we're created very different in a sense in this kind of reality, although we have some equal basis in this particular way of seeing things. And again, instead of tackling my avoidance as like blindly just going ahead and saying, I want to give you this kind of therapy where it would use behavioral activation, for example, in the psychotherapy sense, I would actually kind of treat my avoidance behavior as opposed to making sure that actually you tackle Jillian's approach problem there that we talked about earlier. So again, what does this mean? And again, so what in the context of eating disorders and eating behaviors? And the goal of part number 2, and again, this is an open discussion that I would really appreciate your thoughts and your ways of proving this wrong, not right. And I'm actually tackling this as a true empirical skeptic. I come from that school of philosophy, and I really would love to see how this does not work for you as opposed to works for you. And how can we actually kind of take this away from the kind of binary symptom? I'm sorry, binary categories and categorization of what we call eating disorders, and how can we design individual-centered treatments that could be easily scalable at the community level based on this kind of understanding. And with that, I'll come to a stop. So Jillian and Julie, all yours.
Thanks so much for that. So I'm going to ask a few questions, and then we're also going to take a few questions from everyone listening. We would love to hear what you have to say. So my first question for Mohammad is, why is it important to create a model that's as simple as possible without being oversimplified? What's the importance of this both scientifically and in practice clinically? Why do more details take away from the model?
I really thank you, Jillian. I really like this quote. It's by Albert Einstein, who says basically to kind of simplify things to as simple as possible, but not simpler. And because if you do simpler, then you're losing components of the system that you're trying to study there. And by losing these particular components, maybe the effect that you're looking at, mathematically speaking, is generated by the interactions of these very simple components that we ignore by looking at abstract models. And therefore, we miss the whole point in this kind of regard. So maybe too much simplification is not an advantage, especially when it comes to mental health with a lot of moving components there. And as such, actually, there is a wealth of examples from other fields. And in particular, let me use weather prediction in this kind of regard, where Edward Lorenz in the 60s and 70s studied the butterfly effect, where the initial states of parameters produced huge differences in terms of what the weather would look like. So similarly, and thinking about this again as a complex system, as a mathematical construct, we need to gauge much more than saying has an eating disorder or does not have an eating disorder in order to be able to fulfill the needs of the individual. I hope this answers your question.
Yeah, it absolutely does. Thank you. Just a reminder, please put any questions in the Q&A section, and we can go ahead and answer them. So my next question is in practice. So how is this three-dimensional paradigm currently used in the common therapies at CBT, DBT, and how can we kind of modify those therapies so that they are hitting these very, very primal components?
Another great question. So unfortunately, I can say they're not properly utilized yet. I can say this paper, my colleagues and I just actually kind of almost published that at Nature Mental Health. But the reality is people have been studying these different layers for decades. But unfortunately, they haven't been properly utilized. So let me give you an example. So if we're talking about CBT, then you would actually start by the interviews of the individual, and assessing their cognitive function there, which is basically the way of modifying the thoughts and the emotions and so on and so forth. But the reality, there is this layer that I was talking about, which is called behavior. That could be a much more sensitive way of gauging that individual's change of cognition, as opposed to the layer above that, which is the thoughts aspect of it. So to this effect, I don't think these particular approaches were sufficiently utilized, except for maybe just thinking about this as a research, from the research perspective. But in terms of tracking patients' changes week by week, and then actually using this as an outcome assessment, or even as a way to properly design and modify the treatment, the therapy approaches, I don't think there has been a lot of work on this front, let alone the fact that we're not even, basically scratching the surface when it comes to using the neural circuit aspect of this, be it EEG, fMRI, PET, whatever it is, to inform the design of these treatments ultimately. And to think about what people are calling these days active ingredients of therapy. So this is, I think, more of an emerging field at this point, but still an emerging field that does not really consider all of the layers. So we're hoping that actually maybe with this effort, this would be something new that people could, distance themselves from the binary systems to kind of focus on individual-centered active ingredients of treatment.
Mm-hmm. Yeah. Thank you. And then my third question would be in terms of medication. I'm sure we have some providers out there wondering about the medication component. So what is the influence of common medications like antidepressants on these systems? Do they work on these systems? Or how can we better pair medication so it's working on the 3 dimensions?
Again, that's a great question. I can based on evidence, let me start with the evidence. We all know that actually antidepressants are, they're a very helpful option, but for example, in patients with depression, another category that I can cite here because of the huge amount of work on it, way more than eating disorders. In the STAR-D clinical trial that was done at NIMH, it's very clear that only 1/3 of the patients ever respond to any kind of pharmacological antidepressants. By the way, the rate is very similar to antidepressants when it comes to psychotherapy, like in general, on average, and then as well as electroconvulsive therapy, as well as neuromodulation, RTMS and TDCS and so on and so forth. So what we're talking about here is, we have all of these great technologies, we have all of these great, chemicals that might be able to help, but what we lack is, how can I optimize the treatment outcomes to give the right patient the right treatment? And again, without a proper system to gauge the different variabilities that I was talking about there, it will be extremely difficult to design such a selection, optimization algorithm, if I may call it, to say, oh, patient A comes with this and this and that, in this layer and this layer and that layer, and therefore they're like a perfect fit for this kind of medications or this kind of treatment therapy, So I don't think we have that data to just go ahead and say, based on the studying of this kind of series of things for that individual, we can decide whether to give them this or that treatment. The reason why this is really very impactful is, in the case of depression, for example, if you give somebody an antidepressant and they don't respond, as per the STAR-D clinical trial, the likelihood of them not responding to anything after that is 90%, 90. So we're talking about a serious problem, a serious major problem. And ultimately, I know that it's echoed in the field of eating disorders as well, significantly. And on the flip side, maybe kind of these behavioral modification approaches, when properly developed to fit the individual's needs, could actually kind of do something, especially in the field of eating disorders, where behavioral modification and breaking habits and thinking about goal direction and thinking about basically kind of breaking the cycle of things would work significantly in this kind of regard.
I just wanted to remind everyone, sorry to interrupt, Jillian, that you can put your questions in the Q&A at the bottom of your screen. If you bring your cursor down to the bottom of the Zoom screen, there's a little Q&A icon. And if you drop them in there, we're happy to answer them. I can also allow you to talk if that helps. Just put that in the Q&A to express yourself. Jillian, sorry to interrupt. Go ahead.
No, thank you for that. Absolutely. Please remember about the Q&A option. So the next question, I asked a question about the therapist, for the physicians, maybe one for the dietitians. How would restricting or binging and nutrition be affecting the system?
Significantly, by all means, because these are the individuals at the forefront of what happens here. So because these are the ones who design the plans for how would you actually interact with the source of the problem, which is be it food, actually, in this kind of regard. So by understanding the different layers, by understanding whether this person comes with, for example, binging or basically bulimia kind of symptoms, and actually with a different layer of thinking about the behaviors that come with this in terms of approach and avoidance and positive and negative, and then maybe potentially even knowing what kind of neural circuits are affected in this kind of regard, then the plan could be significantly different that is proposed by the dietitian for an individual as opposed to other individuals, and actually would allow for much quicker turnover of results for that individual. So selection of the types of food, frequencies, times when that the meals are taken, basically size of the meal, approach or avoidance to particular flavors, things that we know activate particular pathways in the brain and actually lead to enhancement or suppression of particular behaviors. And we'll see actually in the second part of this series, we'll actually look at data from patients and models of binge eating behavior and other eating disorders that would actually allow us to kind of interrogate this particular question even further.
Yeah. We have a question from the audience. Can you give us specifics about how this non-binary approach might look in eating disorder diagnosis and treatment?
Absolutely. So basically, let's think about binge eating as the symptom, basically, or a behavior, like a feature that you would see in a patient. Okay, let me go back to the slide. That would actually kind of help me here. So let's think about like binge eating here as one of these symptoms that we consider. And it's not just binge eating. We need to measure where binge eating is in the context of other symptoms. Again, think of it as a network of things that are happening for this particular individual. And then ultimately, not just I don't only quantify by interviews what happens in this binge eating expression, but I also understand its relevance to other expressions of other symptoms, not just related to eating disorders, but only related to anxiety and depression and so on and so forth. And I go ahead and gauge for the same individual, is this binge eating, for example, because of the significant association between a stimulus and the response, for instance? Is it when they see a particular type of food or any kind of food, or they smell the food, basically they keep kind of like going after the food to binge eat and binge eat and binge eat, which is what we call habit learning. And we can gauge this using the second layer of things by understanding the interactions between stimulus type, approach and avoidance as a response, and then the outcome, is it positive or negative? Because that actually kind of could be easily kind of decoded into a matrix of numbers that would allow us to see where this individual lies in this particular space. And then maybe do an fMRI as a way of gauging the functionality of the hypothalamic area in this particular domain and its interactions with the basal ganglia, for example, the nucleus accumbens and the mental tegmental area, and looking at this voxel by voxel. Voxel is a volumetric pixel in the brain that we study in order to see how these different small areas in the brain interact with each other as a network again. So you see we have three networks: symptoms focusing on binging, behavior focusing on why does this happen along the stimulus response outcome contexts, and then actually the neural circuit that governs this, where for this individual in particular. And then based on that, I know where binging is coming from to some extent. I would know that binging has the basis of this particular behavioral point in space. And I know that this is the circuit that actually is mostly affected by that. And therefore, I design my psychotherapy for binging to fix the problems in the circuit and in the behavior. And then ultimately, I would see the reflections on the long run in the binging behavior, as well as the surrounding symptoms that we call comorbidities now, which we call depression and anxiety and so on and so forth, but maybe they're just part of the same network. And feel free to, I'll be happy to kind of elaborate more, but basically this is what it is. And instead of calling it, eating disorders, we just follow that chain of things and fix the chain of things according to these, particular mathematical and network inconsistencies that we observe, data-driven, that would allow us to treat the individual as opposed to treating the category. I hope this makes sense.
Yeah, absolutely. We have a few more minutes of questions, so please, any last minute questions, put them in the Q&A. My next question might be a little speculative, but I'm just wondering how, in this day and age, social media is influencing these systems and, our eating overall as a result.
Well, social media is influencing everything, especially the youth, actually, to tell you the truth. Let me start with an alarming statistic that the youth suicidal rates doubled over the past 10 to 15 years. And that was basically that marks the birth of what we call social media these days. So I have no doubt that actually by basically the current information age, we're becoming much more habitual in terms of the behaviors that we're following on these particular windows into the digital world, where it becomes more of, I don't think about the outcome and I just want to follow whatever particular model that influencers are setting for me, So, and unfortunately you see this a lot, especially for the youth, where these things that we call trending and things that are happening that are just basically booming and all over social media, and you see all kinds of let me call them interesting behaviors, not just limited to food, not just limited to eating behaviors, that would actually kind of be conveyed by just spreading the pattern of things. So even if sometimes you don't actually kind of follow into the logic of it, you would, being part of that platform, you would just be following in these footsteps to some extent. And I want each one of you, Jillian and our colleagues, to kind of, I want to sometimes to kind of like take a step back metacognitively and observe yourself as you're flipping through things on social media. See how automatic the behavior is, Are you thinking about it? When you say, when you write lol or you put a smiley face, are you actually laughing? Is this funny? So just think about it. Observe yourself as you're doing these behaviors, and it just tells you what the problem is. Because a lot of the times, this is not actual true behavior. This is just following into whatever kind of habitual systems that are being created as part of the collective cognition, if I may call it. I don't know if this is a term, but basically it's more of like following into these footsteps of whatever you observe without even thinking about it, cognitively speaking, behaviorally speaking. And ultimately, if you mess up any of these systems, then actually you will see in the next layer whatever happens. So again, this makes it much easier to think about what really happens if I, just become more habitual. That habitual is not going to just be confined to my use of my cell phone. It could be generalized to something else, to how I deal with my family, to how I basically even think about, my math assignments or something like this,
We have another question for you. I appreciate your support of non-binary thinking and the biopsychosocial model, but I'm not seeing how you integrate the cultural issues that cause and maintain eating disorders when people are trying to cope with stigma, violence, oppression, and eating behavior as part of that. The active ingredients are in human relationships, how we treat each other. Would love to hear your thoughts.
Brilliant, by all means, because basically that's actually something I'm not showing here. And again, it will come in the second part, so please stay tuned for that. It basically shows actually another really very important thing I didn't even touch upon, which is development, So you have development, we have the environment, we have stressors, and we are products of our environments after all. Even genetics doesn't really matter if you're not in the right environment. So you're absolutely right. And actually in this kind of active ingredient algorithmic way of thinking about it, the aim behind this is to get to the point where we can basically but calculate the effects of the, culture and environment as well as development and kind of bake it with this kind of model. And then actually when you deliver the active ingredients, you're thought about as being in the context of these, problems, or not problems, maybe circumstances, if I may call them, that actually, again, it's for that individual under this set of circumstances in this kind of set of developmental factors. So you're absolutely right.
Thank you. We have a comment from Laura. Please do put in any final questions in the Q&A. We have just a few minutes left. But Laura writes, thank you for your great presentation. I want to provide an FYI comment, not a question. I'm reminded a lot of process-based CBT and the work of Steve Hayes and Stefan Hoffman. They are investigating and writing a lot about dynamic systems across multiple domains for optimizing a unique patient's psychotherapeutic treatment outcomes. Looking forward to your part 2.
Well, thank you very much. Absolutely. And I want to add to that, think of layers, it's not just psychotherapy, it's everything that comes above and beneath it as well. So it's a much more complex system. So anyways.
Yes. If you don't mind, Mohammad, just going ahead, forwarding a few more slides. Jillian, if there's anything that you would like to add in terms of questions or comments, please let me know. I wanted to bring up at the end of our discussion here, of course, because we're leaving you with a bit of a cliffhanger, at least for me, in terms of how do we quantify all of this, all of these blurred lines, really, and where do we go with treatment from there? So I'm going to talk about what's next. But do know that if you're interested in balance in the programs that we offer, I am the outreach manager, Mellk, for Balance, and you can contact me. You'll see my contact in just a slide. I'll put it in the chat, but we have a day program, an evening program, a Saturday program, individual nutrition counseling, meal supports, meal exposure, and groups, both virtual and in person. I'm happy to talk with you more about that. So this is 3 points on when to refer, not the only times when to refer, but perhaps when your client is unable to put the work into practice without monitored meals. Behaviors such as binging, extreme food aversion, purging have not decreased, and that's of course not the only behaviors, but some. and to reduce the risk of relapse when someone is stepping down from residential. That's my contact information, but I will of course put it in the chat. So what is next for us with Jillian and Mohammad? This is also our free confidential discovery call number. Everyone can get a 20-minute free consult. I'll put that in the chat as well. But coming up in November, we will have part 2 with Mohammad, and I'll let you, Mohammad, talk a little bit about what we'll explore there.
Thank you, Julie. Yeah, absolutely. So basically, it's the so what component. Yeah, we talked about this kind of really beautiful multi-layered system of circuit behavior and symptom. But what does this mean? I'm a medical doctor by training. I can tell you. So how can I use this? Why does it matter? Would it really kind of modify my way of thinking about how to treat a patient, and how? So that's actually what we'll be talking about in the context of data. Because again, as I mentioned to you, I try to tackle this in the context of being an empirical skeptic, so data driven. So I'll show you a few experiments, results from a few experiments that I did myself or collaborated on, in order to show you kind of the strength of this particular approach, as opposed to the classical binary system that just gives a 1 or a 0.
Thank you. Jillian, any final words?
This is just a really intriguing webinar. So thanks for taking the time, Mohammad, with Balance today. And I'm looking forward to seeing everyone back here for part 2, November 4th. Thanks.
Thank you both for being here. I want to thank all of our guests, our audience. We appreciate you being here. We're so happy to get your feedback and particularly your questions. This is an ongoing, evolving conversation. There's no, end point really to it, and that's pretty exciting. We're happy to provide the platform to do it. So thanks for showing up, and we hope to see you November 4th. You can find this recording. It will be sent out to you, but on our YouTube, and I will put the link also in the chat to that, where all of our webinars exist. Have a great afternoon, everyone. Thanks for being here.